my big red screen. Can someone confirm that they can see it? Perfect. All right. So today's presentation is going to be a general introduction of Parkinson's disease. We're going to cover what Parkinson's disease is. We're going to talk about the motor signs of Parkinson's. And there are four main signs that a physician will look for when they're diagnosing someone with Parkinson's disease. Signs are something that a doctor will see upon observation at an appointment. And symptoms are things that a patient reports to the doctor that aren't necessarily visible to others. We'll talk about some of the non-motor symptoms of Parkinson's disease. We'll cover some Parkinson's medication information and why it plays such a critical role in the wellness of someone living with Parkinson's disease. We'll cover some self-management tips for Parkinson's disease and also discuss some care partner challenges and coping techniques as well. So explaining Parkinson's can be somewhat confusing or overwhelming at first. So to ensure that we're all on the same page, I'm going to break it down in terms of each of the words that get used. So it's chronic, progressive, neurodegenerative disease. And I know that's a big mouthful, but chronic means that it's there for your lifetime and that it doesn't go away. Progressive could be something that people might find a bit confusing. Most of the time when we're talking about things progressing, they're usually in the positive sense. I've got 3 kids and within 15 months, they're all getting married. Things are progressing. When you talk about how is the wedding plans progressing, we're talking about things in a good sense. But when we're talking about Parkinson's disease, we're talking about the effect that the disease has on your daily life and the amount of impact that it's having. So it's also neurodegenerative. Neuro refers to what's happening in the brain, and degenerative refers to the fact that the part of your brain that is responsible for helping you coordinate movement is slowly dying off so that you're having less ability to control your movements over time. So it is not contagious and it's not, or nor is it fatal. Some people think that they might have done something wrong to cause this to happen, and so they think that they might be tainted. And there's a lot of things that have changed in the last 60 years or so. It used to be considered a fatal disease. Within about 5 to 10 years of someone being diagnosed, people would pass away because they had Parkinson's, but that is no longer the case. People don't die from Parkinson's disease in and of itself anymore, but they will have secondary complications, but it'll be within a relatively average lifespan compared to someone without Parkinson's. And that's quite different from memories that older adults might have of relatives or neighbors who have had Parkinson's prior to the 1960s. Now, dopamine is a very important chemical because it helps coordinate smooth muscle movement by carrying signals between the nerves of the brain region that control movement, balance, and coordination. It's also important to note that dopamine is also the it's part of the pleasure center of your brain and the reward center of your brain, and we'll bring up why that is so important in a little bit. But when those cells in the brain that produce dopamine, they start to die off. And when it gets to a certain point, that's when the symptoms of Parkinson's disease appears. So this picture represents a loss of that neurotransmitter dopamine, and that's those little green dots you see on this screen. So for someone without Parkinson's, as you can see in the top picture, there's lots of dopamine. So when those neurons are sending the messages and the grabber, the cells, when they're grabbing those messages, there's lots of little messengers to send them through. But with someone with Parkinson's, there's a lot less of that dopamine to carry the signals through. And so a lot of times those signals don't make it through to where they need to be, or they get delayed. There is no way to predict how quickly or the way in which it's going to progress because each person is different. We say, if you've met one person with Parkinson's, you've met one person with Parkinson's. Parkinson's is primarily a movement disorder. Now, because of that lack of dopamine in the brain, people who have Parkinson's will have difficulty controlling their movement purposefully. They'll experience tremors, their muscles may stiffen, and they will slow down. This slide shows how, as we all age, the amount of dopamine that's produced in our brain declines naturally anyways. The blue line shows a person without Parkinson's disease. And as you can see, over time, as the people age, less and less dopamine is produced in time. Um, the difference for someone with Parkinson's is that it happens sooner and much more rapidly than for someone without Parkinson's disease. So it's interesting to note that by the time that you actually notice symptoms of Parkinson's, which is typically like a tremor in your hand or dragging of a foot or something like that, where you think something might be wrong, I might need to talk to my doctor. By the time that happens, you've lost about 80% of the dopamine that's produced in your brain. And if you think about it, that's actually quite amazing that you can lose 80% of the function of a part of your body and not only still be alive, but be able to function without even really noticing that something is wrong. So what doctors do over time is they will increase the amount of medication to help make up for the shortfall, and they'll also change the frequency that you take your medication. So there's a song, there's a hole in the bucket, dear Liza, dear Liza. I liken that bucket to the amount of dopamine, that minimum amount of dopamine that you need in your brain to keep yourself able to control your movements. But there's a hole in the bucket. So that bucket isn't always staying full. So what you have to do is you have to take a cup of water, a cup or a ladle, fill it up, and occasionally put more water in the bucket to keep it full. And at first, it's not that big of a deal. Every once in a while, you just put more water in and it stays in that range where your movements are under control. But that hole gets bigger and bigger as time goes on. And so you're losing water faster. So you either have to use a bigger cup or you have to fill it up more often to keep that bucket full. And that's pretty much what the pills are like too. You have to have bigger dose or do it more frequently to have that, to stay in that full bucket range. And sometimes you have to do both. You have to use a bigger cup and do it more often too. Part of the problem in diagnosing Parkinson's disease is that the area of the brain that's responsible um, for producing the dopamine, it's really hard to get to. You can see in that cross section of that man's brain, it's right smack dab in the center of the brain, halfway in, halfway down. So it's very hard to get to. Now in that top picture of someone without Parkinson's, that dark area, it's actually um, it's called the substantia nigra, which literally means black matter. And that substantia nigra makes the dopamine for your brain to move, to help you control your movement. So in the lower picture, you can see there's a lot less of it, and that would be someone with Parkinson's. So they've got a lot less of those dopamine producing cells over time. Right now, the only 100% confirmed way to be sure that someone has Parkinson's is upon an autopsy, and nobody wants to sign up for that early. So what happens right now is the doctors will do they'll do testing, and they'll they'll talk to you at appointments to find out what kind of symptoms you're experiencing, and they'll come up with a relatively good guess as to whether or not it's Parkinson's or not. Now, some exciting news that actually just happened in the last couple of weeks is that the Michael J. Fox Foundation um, released news that they've got a new test that it'll test for a hallmark feature of the disease. Um, there's something in the brain called alpha-synuclein, and it's a protein. And for people with Parkinson's, one of the hallmark signs of someone with Parkinson's is that those proteins have kind of folded over funny and clumped together. And they've found a test that is highly accurate in identifying people with Parkinson's, as well as people who are at high risk of developing the disease. And that biomarker test has a potential to be used at the clinical level in the future. So it's very brand new right now. It's not something that's in a format that can be used by doctors right now, but hopefully in the future that will lead to tests so that doctors can get diagnoses sooner and people can get treatments sooner. But right now, we're still at the clinical stage. So that Parkinson's diagnosis can actually take some time. A family doctor or a family member might notice some of those signs at first. They might notice that you're dragging your foot, or appear to have a frozen shoulder, or there could be some tremors. And so you'd be referred to a neurologist to do some testing. And a neurologist is a specialist who deals with Parkinson's as well as other conditions in the brain. There are no tests or x-rays to confirm Parkinson's. So the neurologist will check your medical history, they'll do a careful physical exam, and they'll do some tests and rule out other conditions that might resemble Parkinson's. I often have people say, you know what, the doctor did an x-ray, a blood test, a CT scan, and he found out I have Parkinson's. No, what they're doing is they are testing for things that have symptoms that are similar to Parkinson's. And when they rule those out, it's more and more likely that it's actually caused by Parkinson's disease. The cardinal motor signs that they're looking for is remembered by the acronym TRAP. T is for tremor, R is for rigidity, A is for akinesia or bradykinesia, and P is for postural instability. The T, the tremor, is a resting tremor. When the limb is resting, the tremor is much more noticeable. So when the person who has Parkinson's, if they go to perform a task, like if they're watching television, they go to pick up the remote control, they hold their hand out with the remote in front of them, and they push some buttons, adjust the volume. For that time, their tremor may appear to have disappeared, but if they hold their arm long enough, those tremors will start to come back again. Tremors are more often constant in the advanced stages of the disease progression, especially if they're not adequately medicated. At any stage, tremors can be difficult to control, but at least in the initial stages of the disease, most people find it more annoying than it actually is something that's disabling for them. Rigidity refers to stiffness of muscles. People might feel like they have a frozen shoulder or they're dragging a foot, and a doctor can feel for passive resistance when they're moving a joint. So if they ask someone to hold their hand out and press on the top of their hand to see if there's a range of movement, mine's got relatively decent, but for someone with Parkinson's, it's almost like trying to move a mannequin. There's just not that range of movement anymore. So that's another test that they will do. Akinesia means lack of movement, and bradykinesia means slowness of movement. A person with Parkinson's can still move, but they will do so more slowly, and so they'll need extra time to do simple tasks like dressing. Postural instability can refer to both balance and gait-related issues, um, and they're normally one of those last symptoms that can appear for someone with Parkinson's. People with postural instability, like this the picture here of the gentleman, they have a more stooped posture. Their bodies are more leaning forwards. They've lost their arm swing, or it's greatly reduced. And if you think about when you're walking, your arms swing in opposite motion to the legs. So it helps to keep you balanced. And so when you don't have that anymore, you're much more likely to lose your balance if something happens. They also have something called festination, and that's when the steps are really short and rapid, like do 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 do, and that often will happen if they've come to a doorway, a visual break in the surface that they're walking on, like that doorway, having to turn a corner, they'll be walking and all of a sudden they just stop. And so it'll take some techniques to reset themselves so that they can get started moving again, because for their brain had the motion going and all of a sudden there was a change and there wasn't enough dopamine for them to manage sending the signal about the change from their brain to the part of the body to turn the corner or to step through a doorway. They also can experience freezing episodes where that message isn't getting from the sender signals to the grabber signals, and all of a sudden they're just like a statue again, and those can be very difficult. So when you put all of those symptoms together for this gentleman, if he's already shuffling his feet because he's not got big movements anymore, his arms aren't swinging in opposition to keep him balanced, he's already leaning forward, he has slowness of movement, he may not have He'll have a delayed reaction if he's more at a risk of tripping and falling. And when he does fall, because he doesn't have enough dopamine, he doesn't have that quickness or even sometimes the ability at all to catch himself. So people with Parkinson's are at increased risk for falls, and when they fall, they'll just crash. They often can't catch themselves either. There are different drugs to treat Parkinson's, but the gold standard is still something called levodopa. Levodopa is a pill that gets absorbed into your small intestine. It goes into your bloodstream, makes its way up to your brain, and once it's in the brain, it gets converted into dopamine. People ask, why can't you give someone just pure dopamine? But there is something around your brain called the blood-brain barrier, and it's a protective shield that filters out external chemicals to keep your brain functioning optimally. And that's not going to let pure dopamine into your brain. And there's a doctor in Winnipeg, and he told a story once to explain how the blood-brain barrier works. And he says he's a generally decent-looking guy, and he went up to a nightclub, and there's a really long line at the nightclub, and he knows he's not going to get in. So he goes up to the bouncer and says, I'd like to get in. And the bouncer looks him up and down and says, back in line. So he knows he needs to get in there. So he calls up his really good looking friend, and his friend comes, and they go up to the bouncer again. And his friend says, yeah, I'd like to come in. And the bouncer looks him up and down and says, sure, come on in. And his friend says, okay, but I'm bringing my friend in with me. And in they go. So all the other components that are part of that pill are the really good looking friend that helps the medication, the levodopa, get into the brain where it can be converted into dopamine. It's important to note that levodopa should be taken with a full glass of water so it can be properly digested and make its way to the small intestine where it gets absorbed. People with Parkinson's, everything is slowing down. Their body movements, their digestive system also slows down. So it's important that the pill, because it doesn't get absorbed in the stomach, it has to make its way to the small intestine. So you've got to give it enough water to help it get there. For many people, a protein around the same time as taking your pill, and it's not for everybody, but for some people, that protein can interfere with the body's absorption of the medication, and then it gets flushed out as waste. So if someone with Parkinson's is taking their medication and they're thinking that they're not getting the best results from that dose of medication, it's recommended that they try taking that protein an hour before or an hour after they take their pill, so that that pill has no interference from protein and it has the maximum amount getting absorbed into the bloodstream and making its way to the brain. The slide shows an example of how levodopa works with your brain's dopamine to keep you in something called the therapeutic window. And that is the time when your symptoms are best under control. And for someone with Parkinson's, we call that when they're being on. So as you can see on the left-hand side, that's early on in the stages of the disease. And that bucket is almost full. It's almost full, but not quite. And so you only need a little bit of medication to keep you in that therapeutic window. So you can see the curve. You take the medication, it gets you up into that therapeutic window, it hits its peak, and then it starts to go out of your system. And then you might have some off periods again. And off is when you are not having optimal use of being able to control your movements. And then you take your dose, and then it goes back up to the next one. So that sinuous curve shows someone taking their pills throughout the day. And you can see early on, for the most part, people with Parkinson's have a really big therapeutic window. So for the most part, they're on. But as time goes on, you'll see that that therapeutic window gets narrower. You'll have greater periods of time being off, and you'll also have potential for a delayed on, and that is often a result of constipation. So if you don't get your pill to get to your small intestine where it gets absorbed and makes its way to the brain, you're not going to get the effect of that medication. So sometimes someone will take the pill, and instead of it having the effect a half an hour to an hour later, there isn't one. So your whole digestive system is slowed down. Now it's time for your next pill. You take the next pill, and somehow it magically makes its way where it's supposed to be and kind of catches up with the other one. And now you've got almost like a double dose. And so you end up in that upper range where now you've got too much dopamine in your body or in your brain. And those cause dyskinesias. So if you've ever driven down the road and gone by like a car dealership, and they've got those big blowing machines outside with those tubes that look like people, and they're flailing and bending over. That's kind of like what somebody with Parkinson's who's having dyskinesias will look like. They have exaggerated movements that they can't control. And if you think about it, that puts you also at a risk for increased falls, because now you can be writhing yourself right out of a chair or out of bed. So those are dangerous as well. Um, What else? There is no limit to the amount of levodopa that a person can take. It's just what a person can tolerate. So if that bucket is getting closer to being empty, then you just need more cups to fill it up. And so there is no limit. What they'll do is they will give you more medication until they see that suddenly you're having more dyskinesias. And now they know, okay, well, the last dose must have been right at the top of that bucket. That this additional dose kind of put you over the top, and now the bucket's spilling over. So we're just going to drop you back down because now we found out where you are optimally right now. It's important to note that Parkinson's is not that it is a multi-system disease. It's not just a movement disorder in the strictest sense. The longer the person has it, the greater the chances of these additional symptoms appearing. Non-motor symptoms are not managed by levodopa, but they may be treatable. So it's important to let the doctor know what you're experiencing. Many of the non-motor symptoms actually begin quite a few years before someone actually gets diagnosed with Parkinson's, because those physical symptoms are now starting to appear. And some of them are being looked at as early biomarkers or indicators of the disease. Some of the most common non-motor symptoms are constipation. And I know nobody wants to talk about poop, but it is incredibly important. About 75% of people living with Parkinson's disease experience constipation. It can be easy to manage at first by drinking more water, exercising, having more fiber, etc. But as the disease goes on, that gets harder and harder to control. Some people will find it very embarrassing to talk about, and so they'll suffer needlessly. But if you don't get it treated, number one, your pills have to get to your small intestine. So if you've got constipation issues, you're not going to get the best results from your medication, and your symptoms will be worse. But on top of that, if you have really bad constipation and it doesn't get taken care of, you end up in a lot of pain and you'll end up in the emergency room. So make sure that that's something that you talk about if you're experiencing it, because 3/4 of the people with Parkinson's do experience that. Sleep disorders are also very common for people with Parkinson's. Something called rapid eye movement disorder is common. Um, the part of your brain, that substantia nigra that's in the middle of your brain that controls movements, it's also the part of your brain that paralyzes you when you're sleeping, and it's impaired. So people with Parkinson's tend to act out their dreams. They might be shouting. Unfortunately, that can mean that their sleep partner might get punched or a kick in the middle of the night or disturbed by shouting, someone jumping out of bed. I've seen photos of a gentleman who he was dreaming that there was a home invasion, and he leaped out of the bed and hit his cheekbone on the corner of the dresser, and he almost lost his eye, but his whole upper face on one side was just black and purple. So it can be quite dangerous for people who have that impairment, that now they're acting out all of their dreams. Fatigue, insomnia, and excessive daytime sleepiness can also occur in Parkinson's disease. About 30 to 40% of people living with Parkinson's may experience anxiety, and about 50% will also experience depression. And we're not talking about someone who is having a hard time handling the news that their life looks different than what they thought it was going to be as they aged. We're talking about the chemical changes that are happening in the brain, and they often have been happening for years before they've gotten that diagnosis. People who get diagnosed, you find out that they've been treated for depression or anxiety for the last 5, 6 years. It's very common. And so um, there's a stigma about talking about Parkinson's, so a lot of people suffer needlessly. There are treatment options, including medication, meditation, and talk therapy, and those can often work very well for people. So please talk to your doctor if you're experiencing these symptoms. And if you remember when I was saying that that pleasure center of your brain, those little pleasure messengers, because they're impaired, the grabbers, like there's the part of your brain that sends the messages, the dopamine, and then the little message grabbers. The message grabbers are like the pleasure center, and they're not getting those rewards. So if someone is told it's good for you to exercise, or it's good for you to make sure you take your medication on time, it there because of the lack of that reward center, eh, they're not all that worried about it, or they don't care enough to do something about it. So there's actually a huge motivation challenge for people with Parkinson's, and that's important to note that they're not doing it because they're just being stubborn or they've lost hope. It's because of those chemical changes in their brain that they're having some of these emotional challenges. Smell and taste. It's important to note that about 90% of people with Parkinson's have lost their sense of smell, and a lot of them have lost their sense of taste. I would have people coming into the office saying, my doctor says I have Parkinson's, but I don't really believe it. I don't know. I have a hard time believing it. And I would say, how's your sense of smell? And they'd look puzzled and they'd say, I haven't been able to smell anything for 10 or 15 years. And I'd say that is a hallmark sign of almost everybody with Parkinson's has an impaired sense of smell. Now, that doesn't mean that if you've lost your sense of smell or you have a reduced sense of smell that you're going to get Parkinson's, but it's something that doctors are looking at as an early biomarker. Um, and if you think about it, what makes you want to have your dinner? It smells delicious and it tastes delicious. But if someone can't really smell their food and they're not tasting their food, they're not getting that much enjoyment out of their meals anymore. And because it's a movement disorder, um, the ability to chew, to swallow, all of those body movements can be impacted by Parkinson's disease. So it can be physically difficult for someone to chew and swallow their food, and their bodies are slowing down. So eating can take longer, it can be more difficult, and they may not be enjoying it. So people with Parkinson's are often um, losing weight because they give up on a meal because everyone else is long gone and finished. They're not enjoying it. It's been too hard and challenging for them, and so they give up. And so a lot of people with Parkinson's end up losing weight, and that can become an issue for them as well. Many people are afraid to talk about cognitive issues, but if someone does develop Parkinson's and they have cognitive issues, they're usually very mild. The two most common impairments are bradyphrenia and executive function. Now, when I mentioned bradykinesia means slowness of movement, bradyphrenia means slowness of thought. So a person with Parkinson's will just take a bit longer to process what's being said and to formulate and to act to be able to speak in their response. Um, and for executive function, that means multitasking basically. So if you've got a bunch of steps that someone has to do, that might be a bit overwhelming for them to be able to remember all of those steps. But if you break it down by giving them one or two at a time, they're quite capable of still managing their day-to-day life, but just with a little bit of adjustments of how you're communicating um, things for them to do and to be organized. The number one thing that a person can do with Parkinson's is exercise. And I hear it all the time. Yeah. That's the cure for everything. It really is true for Parkinson's. Exercise has been clinically proven to slow down the progression of the disease, because when you exercise, your body gets flooded with other chemicals, and that flood of dopamine is part of those chemicals. They have some neuroprotective qualities for your brain cells. And when you're exercising, people with Parkinson's report that their symptoms are lessened or they disappear for a while and for a period of time after exercising. So it's so important. People who exercise with Parkinson's stay well for a lot longer than someone who doesn't exercise. And we're often asked, what is the best exercise for someone with Parkinson's? And it's the one that you're going to do. So if you already exercise, good for you. Maybe try something new so that your body and your brain aren't automatically knowing what to do. So that challenging your brain while challenging your body at the same time will have benefits and neuroprotective qualities for your brain. Um, it also will help improve your muscles. It will help you improve your balance and your flexibility. And it'll also help you, for instance, if you're doing cycling or something, or doing something that involves like marching or something like that, because of the foot shuffling, those smaller movements, that exercise will make your steps higher. It'll make your stride longer. It'll help your arms keep that swing going, and it'll help keep you upright longer. So there's a lot of safety benefits to the exercising as well. Stress, whether it's bad stress or happy excitement like planning 3 weddings, it's still stressful. And those symptoms will be affected because of the stress, whether it's good or bad. So it's important for people to manage their stress. Mindful meditation is one of many ways that people use to control their stress levels. And so time management is super important as well. Parkinson's may not slow you down, or sorry, it may not stop you from doing the things you like to do, but it will slow you down. So if you're rushing, it's going to increase your stress. And if you increase your stress, the chemical balances in your brain are going to all be shifting, and it can affect the dopamine and the ability of your brain to send the signals to your body to move. So your symptoms get worse. So it's not like if you're living in say an apartment block, and there's a bus coming, and you're saying, Mr. Jones, the bus is going to be here in 5 minutes. You need to get your shoes on and your jacket on. Mr. Jones is now stressed. Now Mr. Jones can't get his shoes tied up, and it looks like he may be just being stubborn, but it actually is the stress has caused him to now not be able to physically move and do the things he needs to do. So give someone with Parkinson's extra time so that you have less stress and they can still do the things that they want to do um, with less impairment. It is so important to keep up communication when you have Parkinson's. It's important to tell the specialist and your family doctor and anyone that's in your family care circles what you're dealing with, so that they can help you look at treatment options and different ways of getting things done. It's important to let those loved ones know what you're experiencing, because it's not always apparent. When we talk about the brain sending signals to your body to move, your brain sends signals to your face as well. So if you're surprised, you might have, a little O made of your lips, and your eyebrows might be raised, or you might furrow your brow if you're a little bit, if you don't understand something, or you're concerned, or you might have a little smirk if someone tells you a bit of a funny joke. But for someone with Parkinson's, their brain is not sending signals to their facial muscles automatically. And so it's something called the Parkinson's mask. They look like they're staring right through you. They might appear to be angry or totally disinterested in what you're saying. So it's not going to be apparent. So you've got to ask them. And if you have Parkinson's, tell somebody what you're thinking. Tell them what you're feeling, because it's probably not going to be apparent in your face. And it's also important to let people know what you can and can't do so that you can adjust your plans and not have to cancel them. About 35% of care partners who care for someone with dementia, multiple sclerosis, and Parkinson's report feeling stress themselves. So if you are a care partner for someone with Parkinson's, start fitting yourself into your new role. People with Parkinson's should do as much for themselves as possible and live as independently as possible with some support from their care partners. And what role that is will need to be discussed and agreed upon on a continuing basis. So communication is important. And that can change not only from month to month, it can change from day to day, or because I've explained about the stress or about the freezing episodes or the delayed on periods, it can change from hour to hour. So always make plans, but be prepared to change them. Be aware that those symptoms can vary widely, even throughout the day. So here are some tips to help you as a care partner. You want to stay close with your loved one. So try adjusting your favorite activities so that it's something that your loved one can still do, or find new ones that you can do together and still remain close. Try planning social activities, medical appointments, dinners with family or friends, or outings or exercising during times of day when your partner is on so that they can be fully participating. Some people with Parkinson's experience changes to their voice or speech, and that can make it difficult to understand them. It's important to note, though, that communication challenges don't necessarily mean that someone is having cognitive issues. Participating in speech therapy can often make a marked improvement. The ability of someone to self-monitor their own volume can be impaired in Parkinson's. There is a speech therapy program called LSVT Loud, and it's a one-on-one session that you do with a speech and language pathologist. And I can't remember what the tool is called, but it's a thing that measures your the decibels of anything around. And so the speech therapist will model a normal speaking voice, and then the person with Parkinson's will speak, and they'll see that they may think their voice is in a normal range for hearing, but they'll see how much lower it is. And there's a lot of exercises they do to get themselves to stay in that range where they can be heard in the normal range. And for them, it'll probably feel like they're shouting, but it will start to become internalized, just like how exercising can help you automatically lift your feet more. It'll automatically help you raise your voice and know how loud you have to feel you're being so that you can still be heard. And that will make a big difference to being understood. So here's some tips for the care partner. Choose a time when a person's medications are on the best period of being on to have important conversations so that they can fully participate. Pay attention to how you're speaking as well as what you're saying. Speak clearly and with short sentences, and that's because of that executive function. You don't want to overload their brain with too much at once. And also be sensitive to your tone of voice. If you're sounding impatient or frustrated, the person with Parkinson's is going to pick up on that, and they're going to get stressed. Their symptoms are going to get worse. So try to make it as easy as possible for them to feel like they're still participating as much as possible in the conversations. Give them extra time to respond. That bradyphrenia, that slowness of thought, the less dopamine sending signals to your throat muscles and your lips and your tongue, all of that can make it harder for them to answer quickly. So give them extra time. You want to remain an engaged listener through nonverbal cues, like you can nod your head, you can touch their arm, and remain with eye contact if that's culturally appropriate for you. And another part for someone with Parkinson's, in addition to having a tremor in the voice, um, they don't get their voice out, and they may not have had speech therapy. So if you ask them to take a deep breath before they say something, if they've tried, when you take that deep breath, now you've got a lot of air pushing your diaphragm, pushing out your voice out. So that will help them a lot to remind them to try again, but take a deep breath first. And as I said, that whole facial mask, You can't rely on their facial expressions to see how they're feeling about what you're saying. So ask them, what do you think of what we just said? Or how are you feeling about that? And get them to tell you rather than relying on how they're looking about it. Managing these unpredictable symptoms, concerns of stigma, and the emotional impact of living with or caring for someone with Parkinson's can lead the care partner to feeling discouraged and isolated. And when those feelings start to feel or look like depression in either the care partner or the person with Parkinson's, get help as soon as possible so that you can get on a treatment plan. Ask for help from your healthcare team, your family, friends, and from Parkinson Canada. We encourage you as a care partner to join a support group. We have groups for people with Parkinson's and for care partners, including for those whose loved ones are in early stages, mid stages, and advanced stages of Parkinson's. And we even have a support group for adult children of people with Parkinson's. There is a saying, you can't pour from an empty cup. Take care of yourself first. And it is so true. If you don't take care of yourself, you are not going to be able to care for someone else. So if you're not used to making time for yourself, now is the time to start. Even just 10 minutes a day reading in a quiet corner can make a huge difference to your own mental health. So now is the time to start thinking of some of these ideas. Set aside time each day, even if it's just a little bit of time, to find peace within yourself in a way that suits you. It could be meditation, it could be yoga, it could be reading. It's something that fills your cup. Eat well balanced meals, do exercises that you enjoy, and get a good night's rest. Now, because of that whole REM sleep disorder, sometimes that might mean having a separate bed in the same room so that you have a gap between you and the person who might be punching or kicking in their sleep. And if there's a lot of yelling and shouting, if there's another bedroom, sometimes people have separate bedrooms for sleeping so that you can wake up as refreshed as possible and ready to face the next day. Um, we also encourage you to maintain a hobby. Treat yourself once a week to something that makes you feel happy and acknowledge your feelings as messages to yourself about how you're actually doing. Find at least one friend you can talk to on a weekly basis and consider joining a care partner support group. And we know that not everybody can get out of the door and out to a local support group, but we also have Zoom groups for people who cannot manage getting to an in-person support group. Ask for support. There are home and community care agencies that can offer services including transportation, personal support, Meals on Wheels, and respite services. Ask other family members to help out and be specific, saying, would you be able to drive your mom to her appointment at 1 o'clock on next week on Tuesday, stay with her, take some notes, and bring her back home? Something that clear, you're much more likely to get someone saying, yeah, I can do that for you, than the person who says, you know if I ever need help, I'll call you, or just let me know if there's ever time you can help. Being general like that, they don't usually happen, but be specific with your ask, and you're much more likely to get someone who says, I can do that. Um, we also encourage you to reach out to Parkinson Canada's information and referral team. They can help point you in the right direction as well. Journaling has been proven to change a person's outlook for the better, even if you're not sharing what you've written with anybody else. So try writing down your thoughts. Caregivers need new knowledge and skills to do it well. So look into caregiver courses on how to do things safely in the home. If money is a source of stress, try to find a balance. Talk with your bank about your options and be sure to explore provincial and federal tax credits for caregivers. And we recently, January of this month, we did a webinar on how to find all the different benefits and credits that are available to you. So if you go to parkinson.ca and scroll down to the bottom to our YouTube channel, and then type in tax credits for search, and you'll find the webinar. And there's lots of great information about how to find credits for people who are disabled as well as for care partners. If you're working outside of the home, try talking to your human resources manager about your work and caregiving responsibilities. Many of the workplace benefits will also include counseling as part of their benefits package. About 100,000 Canadians are living with Parkinson's disease, and that's about 1 in 100 and every 184 Canadians over the age of 40. And about 30 more people are diagnosed every day, and we expect that that number is going to reach about 50 a day in the next 10 years. And we don't know if that's because greater awareness of the earlier symptoms, if more people are getting diagnosed, or if the actual cases are increasing. The average age of diagnosis is the age of 60. That's about 1% of the population over the age of 60. By the time you're in your 70s, it's 2%. And by the time you're in your 80s, it's about 3% of people that will have Parkinson's disease. Young onset, which is under the age of 50, makes up about 20% of people with Parkinson's. It's usually defined as people under the age of 50. However, some doctors state that the age range that they consider young onset to be the age of 21 to 40. So depending on what statistics sources they used for gathering the data, different sources might be quoting different rates because they might be saying under 50 or they might be saying under 50. But in general, the age range makes up about 5 to 10% of all Parkinson's diagnoses. And Canada has one of the highest prevalence rates of Parkinson's in the world and one of the highest rates of new cases per year. So what does Parkinson Canada do? Well, since 1981, the Parkinson Canada Research Program has invested more than $31 million in research funding. We have advocacy efforts through our Parkinson Canada Ambassador Program. We provide electronic and hard copy literature, and it's updated and reviewed by a medical advisory committee. We do special presentations like the monthly webinars that I do. We provide research updates and Parkinson's education presentations like we're having here today. We provide print resources for healthcare professionals. And we also have a 1-800 line and information email address so that our information and referral team can answer your questions about Parkinson's, provide information and community-based referrals on a wide range of social and medical services and local wellness programming inquiries, as well as virtual wellness opportunities too. We have a network of support groups across the country that meet virtually, in person, um, and some of them are even a hybrid of both. So those groups are for people with Parkinson's, and we also have ones uniquely for people who are the care partners. And we believe that education is a key way for people with Parkinson's to live a better quality of life. And learning about Parkinson's will help the person cope with